Hello class, this is Tyler with Jill, Allie, and Celine coming at you with a shocking presentation in which we will inform you about the benefits of extracorporeal shockwave therapy and more specifically if it applies to our patient.
So let's meet our patient through our PICOS question. We are wondering, for a 50-year-old female presenting with left shoulder calcific tendonitis, is extracorporeal shockwave therapy and traditional physical therapy more effective than physical therapy alone for reducing pain and disability? So let's talk about calcific tendonitis. Calcific tendonitis is a painful condition where calcium deposits within the tendons of the rotator cuff, most commonly occurring in the supraspinatus tendon. X-ray is used to identify the calcium deposits, as you can see in the photo on the right. Calcium can deposit and cause inflammation of the bursa around the tendons, which contributes to the pain. Patients will present with signs and symptoms similar to subacromial impingement. They will have limitations like decreased active range of motion, scapular dyskinesia, decreased rotator cuff strength, and positive subacromial impingement signs. Their pain is worse with lifting the arm away from the body, and patients will have issues, especially with overhead ADLs, like reaching into high cabinets, dressing, brushing their hair, and they'll have discomfort when they're sleeping on the affected shoulder. The exact cause of calcific tendonitis is unknown, although it is thought to be related to aging and wear and tear of the tendons.
Extracorporeal shockwave therapy is a non-invasive treatment that involves the delivery of shockwaves to chronically injured soft tissue in order to reduce pain and encourage healing. It's typically used for those whose conditions persist for longer than 6 months and have not improved with other conservative treatments. It's commonly used for conditions such as plantar fasciitis and various tendinopathies.
Shockwave therapy machines produce sound or pressure waves that can pass through solids, liquids, and gases. The pressure wave contains both positive and negative phases that can have an effect on tissue, and it's the negative phase specifically that results in cavitation or tissue damage. This causes the formation of air bubbles, which will also result in a second bout of shockwaves, and this causes microtrauma that stimulates the body's natural healing process. So how would it affect calcific deposits though? Unfortunately, calcium reabsorption post-shockwave therapy is not fully understood. It's hypothesized by Brañas et al. That the mechanism is due to the presence of neo-lymphoangiogenesis phenomena, aka the development of lymphatic vessels.
Outcome measures. The constant Merle score is a 100-point scale composed of a number of individual parameters. These parameters define the level of pain and the ability to carry out the normal daily activities of the patient. The test includes 4 subscales: pain, worth 15 points, activities of daily living, worth 20 points, strength, worth 25 points, and range of motion, worth 40 points. The higher the score, the higher the quality of movement. The time needed to complete the test is 5 to 7 minutes. The 2 pain scales used in our studies include the visual analog scale and the numeric rating scale. The VAS and the NRS are both pain scales where the patient selects a whole number, 0 to 10, that best reflects the intensity of their pain. Typically, the VAS includes a visual representation of the patient's perception of their pain. Standard radiographs and anterior-posterior, outlet, and axillary views are used for diagnosis and follow-up of calcific tendonitis because they allow localization and assessment of the texture and morphology of the deposits.
So here's our final search strategy from PubMed. Our strategy was to divide and conquer, so here's our final yield.
The first study we are presenting is Wang et al. 2003, titled Shockwave Therapy for Calcific Tendonitis of the Shoulder, a prospective clinical study with 2-year follow-up. 37 patients with calcific shoulder tendonitis were treated with shockwave therapy and 6 patients in the sham control group. The orthopedic staff were blinded during follow-up evaluations, but the patients knew which group they were in. In the study group, there were 23 females and 14 males, and the average age was 51. The inclusion criteria included patients with shoulder pain attributable to calcific tendonitis who had failed to respond to at least 6 months of non-operative treatment, who might otherwise have considered surgery as an alternative. This study was not randomized, so patients opted out of the control group. This article was selected because it matches our patient description, isolates shockwave therapy, and analyzes the patient's symptoms of pain and disability. The study did not compare shockwave therapy to PT or in addition to PT. All the patients discontinued the treatment they were currently receiving, including medications and physical therapy, before the study to limit skewing results. Outcome measures used include the constant Murley score, visual analog scale, and radiographs of the shoulder. 6 patients were excluded due to inadequate data or poor compliance. Repeated application at 30 to 60 days was provided to patients whose response to the initial treatment was inadequate. 27 of the 31 patients in the study saw improvements after just 1 treatment. 8 patients received 2 treatments, and only 1 patient with bilateral involvement needed 3 treatments. In the control group, all 6 patients were observed for 5 to 8 months, then decided to seek alternative treatment, including surgery, because of persistent or recurrent symptoms. After treatment, statistically significant differences in CMS scores between the treatment group and the control group were observed. In this study, 60% were complaint-free and 30% were significantly better after treatment. There was a statistically significant reduction in the average size of the calcium deposit in this study group, and 57% were completely eliminated. None of the patients that obtained complete dissolution of calcium deposits showed any recurrence at 2 years after shockwave therapy.
So the next study we're going to talk about was conducted by Gerdes-Meyer in 2003. The purpose of the study is to compare the effectiveness of high energy and low energy extracorporeal shockwave therapy versus placebo in conjunction with physical therapy for patients with chronic symptomatic calcific tendonitis of the supraspinatus tendon. The study is a double-blind RCT with 144 subjects. The average age of the subjects was 50.4. After randomization to groups, subjects received 2 sessions of shockwave therapy treatment and received 10 sessions of physical therapy after the intervention. The outcome measures were the same as in the study discussed previously by Wang et al., and the study was selected because it has a large sample size, excellent internal validity, and most closely matches every aspect of our PICOS question. Changes from baseline at 3, 6, and 12 months were observed. The take-home point from this article is that high-energy shockwave therapy plus physical therapy is superior to both low-energy shockwave therapy with physical therapy and physical therapy alone. When looking at patient scores in the high-energy group, patients scored superiorly on all outcome measures and showed a statistically significant difference when compared to the 2 other groups. In addition, complete disappearance of calcific deposits was observed in 60% of the patients in the high energy group after 6 months and 86% after 12 months. What was interesting was that the low energy shockwave group and the sham group had similar results on all outcome measures and were both inferior to the high energy group. Patients in the low energy and sham group had the lowest CMS scores, highest pain scores, and least calcium reabsorption. These patients also required more pain medication and were more likely to undergo surgery when consulted in a follow-up evaluation. Overall, this shows that parameters matter. Patients will not get the same extent of improvement with low energy shockwave therapy or with physical therapy alone.
Hawk et al. Performed a prospective blinded trial with a randomized 2-sample parallel group design to look at how the location of applying the treatment could change the outcome. Many protocols focused on the ESWT on the origin of the involved tendon, but Hawk wanted to see if it made a difference by focusing directly on that calcific deposit. They saw that while both protocols helped, the direct focusing of the deposit had significantly better results. Something I think is cool is that they actually saw that even if there was no significant differences between the group, the calcific deposit was resorbed in many of the cases. So with this treatment, they were not only able to help with pain and function, but they were actually able to fully remove the deposit that was causing the issue in the first place. Here is a table of the values that showed the significance of these findings. I specifically highlighted the constant and Murley scores to show the significance of both the increase in scores over time as well as the difference between the groups. As you can see, the calcific deposit group had their scores increase from an average base of 49 up to 116, while the insertion group rose from an average of 47 to 83. Another highlight is the decrease in pain during activity. Starting with an average of about 8 on the scale of 0 to 11 for each group, the calcific deposit group dropped all the way down to a 2.76, while the insertion group only dropped to a 6.04. This shows how important it is to direct the shockwave at the calcific deposit and how it can help people achieve better outcomes.
Gertis-Meyer's study showed that higher energy shockwave therapy resulted in more improved outcome measures than lower energy shockwaves. However, it is known that high energy shockwaves can be very painful. And as Celine mentioned before, parameters matter, but a threshold energy has yet to be defined. Because of this, Iopolo did a study to compare two lower energy levels, but higher than the low energy dose used in Gertis-Meyer's study of 0.8 to see if these would result in reduced pain and improved shoulder function, and to help contribute to a more standardized dosage of shockwaves. We selected this article because it matches our patient description, intervention, and outcome measures of the CMS and VAS. Unfortunately, there was no control group of just PT treatment. There was a single-blind, randomized clinical trial with 31 female and 14 male participants with an average age of 54.3 years old. Group A received shockwave therapy at an energy flex density level of 0.2 millijoules per millimeter squared, while Group B got 0.1. Both groups got 4 treatment sessions, once per week for 4 weeks. Both groups were able to decrease pain and improve function, and I'll go into more detail on the next slide. So if you'll look at the left figure, they found that both groups were able to improve their CMS values after 3 months with no significant difference between groups. However, after 6 months, Group A was able to show further improvement. In the right figure, you'll see that both groups were also able to significantly decrease their VA scores from baseline, but there was a more evident improvement with Group A again. Additionally, it is not pictured here, but they also had both groups report their numerical rating scale after 12 months, and Group A also showed a lower level of pain than Group B. This may suggest that for patients who cannot tolerate the discomfort of higher level shockwave therapy, it is feasible to use a lower energy of 0.2 millijoules per millimeter squared and still get good short-term and even long-term results. And it's also important to note that there was a complete disappearance of calcification in 50% of patients in both groups. And all the previous studies we mentioned also found reduction in calcium deposits. So this suggests that getting rid of the actual deposits is not necessary to decrease pain and improve shoulder function.
With all this presented evidence, we have concluded that ESWT would benefit our patient, and we would specifically want to use the higher energy ESWT with patient tolerance directly on that calcific deposit to assist with getting better outcomes for our patient and hopefully avoid surgery.
Other diagnoses that could benefit from shockwave therapy include lateral epicondylitis, medial epicondylitis, Achilles tendinopathy, patellar tendonitis, non-union bone fractures, and plantar fasciitis. Here's our references. Thank you.